All right. Welcome, everyone, to the first AIMI IBIIS seminar series of the year. We're super excited to have a fantastic speaker for our first seminar. I'm delighted to be able to introduce Dr. David Ouyang. David is a cardiologist and a researcher at the Division of Research at Kaiser Permanente in Northern California, and also an assistant professor at the Smidt Heart Institute at Cedars-Sinai. I think David has a fantastic background, had his undergraduate degree in statistics, is an MD, and he was actually at Stanford doing a postdoc, really leading cutting-edge work in cardiology and AI. And it is so amazing to see all the research that David and his lab are producing. Pretty much most cardiology AI papers that you have read are either authored by David or highly influenced by David. And David just does fantastic work both on the development of novel AI algorithms for cardiology and really focusing on the implementation of these tools too. So we're delighted to be able to have David join us today to tell us a little bit more about his research. So David, please take it away. Thank you for joining.
Akshay, thank you for the really kind and generous introduction. I'm really excited to be back at Stanford, where I did a lot of training and spent 6 years of my life. So really want to share some of our experience, which is focused on cardiology AI, but with the recognition that, to the first approximation, all of the stuff we do in cardiology AI is inspired by radiology AI. I think that radiology is really at the forefront of both deployment, development, as well as integration of AI, and you'll see a lot of parallels with the work that we're doing, as well as in cardiovascular AI in general, to what's being done by many groups here. I'll focus a little bit about the background, why there's interest, and what are the unifying themes about kind of image processing and computer vision, the clinical need, well, particularly in cardiology, but in general, why imaging is so important to the practice of medicine. And then really 3 vignettes, which is focused on precision measurement. How do we actually do things that computers can do, or humans can do, but do better? Precision detection, how do we detect things that humans are missing? And the question of agentic AI, how do we actually go into the workflow of automating a lot of interpretation tasks? But first, I'd like to show this video, which is a paper we recently published, which I find fun, which is actually, this is a pigeon. So I don't know if you guys remember kind of maybe a couple of years ago, I think around 2018 or 2019, one of the animal psychologists at the University of Iowa actually found that pigeons can actually read pathology slides. When you show them slides, or when you first teach them or show them slides of both breast cancer or not breast cancer, over time, the pigeon can actually identify which is cancer or not cancer. You can imagine birds, because they have to live in the wild, look at very far things, distinguish moving and non-moving things, is actually have a very developed kind of a visual cortex. So a lot of the premise of what we're doing and what cardiologists and radiologists are doing is similar to the pigeon. We're doing pattern recognition. We're recognizing what's important and not important without an intrinsic label. So one might expect this is kind of reinforcement learning, or over time we actually have a reward for developing or understanding what's correct or not correct. But in this case, the pigeon is actually able to, over time, evaluate what is a normal heart, what is an abnormal heart, when you give them a reward, in this case, food. But in my mind, this is really the value and the thesis of imaging in general, whether it's radiology, cardiology, dermatology, pathology, or all in that spectrum, which is the idea is that a picture is worth 1,000 words. This is a picture published in the New England Journal more than 10 years ago, which is actually simply a truck driver. Over decades of driving a car, maybe the same route day in, day out, maybe the fact that the sun is closer to the left side of his face versus the right side of his face, he's had asymmetric sun exposure. That leads to an asymmetric phenotype that we can interrogate by imaging. And this is important because it actually has a correlation with the clinical outcome. Right? Maybe for him, you can both see that his face is a little bit wrinkly on one side, but that has a higher correlation with skin cancer. Maybe Roxana's going to tell him he needs to put on more sunscreen, but really, this is the central dogma of imaging, right? Which is actually, we can understand our clinical outcomes through the imaging. And even though cardiologists are really good at identifying metrics, things that we recognize as really important, we don't recognize everything. So as a cardiologist, we use the ejection fraction, a sense of how well the heart is squeezing, coronary calcium, the risk of cardiovascular disease, delayed gadolinium enhancement, which is the amount of scar that's happening in MRI, All those things are important to cardiologists and patients because that's a correlation with the clinical outcome, right? Whether it's heart failure, MI, death, all these things actually really link the imaging to the outcomes. But it's the tip of the iceberg, right? That's really the promise of AI, because even for clinicians, our understanding of imaging has evolved. This DGE, the concept of scar on the MRI, was something that cardiologists, radiologists did not recognize even 20 years ago, but recognize over time that this is important and has a correlation with the clinical outcomes. But that's also why AI is so potentially interesting and promising, in that it is an unbiased approach to interrogate the vast amounts of imaging data we already have and actually understand this correlation in a way that is a different perspective than how humans actually evaluate. At the same time, we have to recognize that there's tremendous clinical variation. If you go to two different doctors, likely you'll get two different interpretations. They might even look at the images in different ways, lead to different treatment plans, different diagnoses, and different outcomes. But this variation happens at every level. I want to highlight that this also happens on the imaging level, and not just what to do once you have the diagnosis. One key example is that in cardiology, our key metric that we assess is the left ventricular ejection fraction, or EF, or for simple, which is a measure of how well the heart squeezes, and is a way to diagnose heart failure, ways to diagnose kind of heart attacks, and a variety of other clinically relevant features. But even though this is a quantitative measurement, it's the ratio of the heart size that's largest to smallest, systole and diastole. It's actually very biased in how we assess it. So on the top-hand side and the bottom-hand side are actually all ejection fractions that are reported at Cedars-Sinai as well as Stanford over the last 30 years. And I've simply colored the histogram based on whether the number ends in 0 and 5, whether in red, or any other number in blue. EF is a metric between 0 to 150%. But you can imagine that it's supposed to be a physiologic measure, so that you're supposed to actually get measurements just as likely to be 50 versus 51 versus 52. But you can see that the humans actually prefer 0 or 5. Maybe it's the humans aren't sure, so they hedge into an intermediate number. Or maybe there's a lot of reason why a cardiologist would actually prefer to say 50 when it's a challenging clinical scenario. I like to highlight this because it's not physiologic. And it also is not physiologic in the sense that the underlying numbers that calculate this ratio, the ESV and EDV, does not have this relationship, right? The ESV, EDV does not have that preference for 0 and 5 in the same way. How can this be? It is that even for our most quantitative assessments, a lot of clinicians use their clinical judgment to decide what that number is. And sometimes we don't want to give a diagnosis, so we undercall or overcall. And sometimes we do want to give a diagnosis, so we'll overcall in a different way. This leads to blinded intra-observer variability for this key metric. This is enough to diagnose heart failure or not, between 8 to 13%. And it's also an area prone to have a lot of variation, where the American Society of Echo suggests that we measure up to 5 beats in a heart and actually average them to assess the ejection fraction. But in any echo lab that I've been to, in a particularly busy echo lab, even without a core lab or something like that, generally clinicians measure a representative beat. But their choice of representativeness is actually another source of imprecision and bias and variation. And at the same time, this key metric, which is what I would describe as a very simple metric, is the inclusion criteria for all heart failure trials. So all that you know and all that society knows about whether drugs work or don't work for heart failure actually has depended on whether the cardiologist and the radiologist called these measures correctly in deciding the clinical trial and the inclusion of these patients. And because we're in a radiology audience, I like to highlight that it's not about the modality. I have a strong preference for ultrasound, but actually across all different modalities, this is the same amount of variation. One example I like to give is cardiac MRI, clearly a more expensive modality, clearly a very sophisticated modality that has experts that read it, has just as much variation in measuring wall thickness as cardiac ultrasound. The reason that we don't do as many studies for cardiac MRI reproducibility is because it's an expensive study. It's very hard to get multiple images from the same patients. But when people do it, there's just as much variation when they measure even very basic measurements like wall thickness. You can see that radiologists can measure different parts of the heart, can measure different parts of the phase. Sometimes it's not exactly at 90 degrees, but a variety of reasons that ultimately distill that right now, the upper bound of accuracy in medical imaging is gated by human intra-observer variability as opposed to the SNR of the imaging modality itself. Right? Certainly, I would agree that the cardiac MRI is much prettier, has a much clearer delineation between blood pool versus the muscle. But it is because there's so much variation in how humans assess the imaging, even once you acquire the imaging, that's really the biggest area for opportunity. So this is essentially the vision of my lab, as well as what I'm sure many of you guys are doing. Oh, go ahead.
Hi, sorry. I'm having a little trouble hearing you, so you may have said it, but for ejection fraction, was that measured single slice ultrasound, or how was that?
Yeah, no, that's a great question. So for ultrasound, we usually use a technique called biplane method of discs. So it's measured in kind of two axial slices, the 4-chamber and the 2-chamber, and then it's averaged. I would say, obviously for cardiac MRI, it's across a stack, and then it's contoured where it's actually measuring every single frame. But for this particular study, it's not even EF, but it is actually wall thickness. So it's literally measuring the thickness of the heart at diastole.
Thank you.
Yeah. So one of our first projects was really, can we automate the measurement of ejection fraction, particularly for echocardiography, which is actually, this is work with kind of Kurt, Ewan, and James, many people that you guys recognize across Stanford when I was a postdoc. But functionally, this was one of the first video-based models where we actually segmented the left ventricle. You can see in blue is the left ventricle, in yellow is the rest of the heart, and in black and white is the functional image. Create a regression task that actually assesses the ejection fraction and also creates a contour that can be measured in the same way that cardiologists do it. So even before deep learning, there was a lot of imaging approaches to do ejection fraction or segment the left ventricle. The Achilles heel of ultrasound is, again, the image quality. There's many patients that might be a little bit bigger, that might have a little bit of lung disease or retain a little bit more air, that leads to the ultrasound having poor images, similar to the ones on the right. But the main challenge is that these are images that are already still clinically interpretable. That I, as a cardiologist, would still look at these images and still come up with a number, even though that the boundary is not very clear. So with deep learning convolutional neural networks, we can actually show that we have just as much or similar accuracy with high as well as low quality images. And that this is able to go frame to frame, beat to beat, in a way that might be actually challenging for a clinician to do. Again, to calculate it from just a clinical perspective, a sonographer most of the time does the contour just for one beat in systole, one beat in diastole, and it says that's the final number. But because it's software, you can do it for essentially every single frame, every single beat, and across multiple videos across the entire study. And this is really helpful because the heart is not a static organ, and there's a lot of variation beat to beat. One example is atrial fibrillation, where the heart rhythm and the heart rate is very irregular. A slower heartbeat might lead to a higher ejection fraction, where a faster heart rate can lead to a smaller ejection fraction. So we can see that, because it's an automated solution, we can actually measure it for every single beat and then actually have a point prediction of ejection fraction for every single beat, and then lead to a more precise assessment of ejection fraction. So this was the state of the art in 2020. Yet at that time, we were very proud of our paper, and we really wanted to, talk with Stanford Hospital, as well as many others, on how to deploy this clinically. What we found is actually, over that time, there was maybe about 300 FDA-cleared products. Now there's about 1,300, but it's not necessarily the entire bar or everything that hospitals are looking at in terms of deciding what products to adopt or even what products to purchase. The example we like to give is that in our analysis, and this with Roxanne as well, this had very few, or FDA-cleared products, in general, are cleared even with very few multi-site studies. The vast majority only had retrospective data, and at that time, none had actually undergone a blinded or randomized clinical trial. It's something that I think for most clinicians, they recognize FDA clearance is important, but it's necessary but not sufficient. An example I'd give is that for the clinician, we think of this as the same bar as when we think about a new medical therapy, or when we think about a new device therapy or implanted device. But the FDA's bar for therapeutics is actually much higher than the FDA's bar for diagnostics, where for the newest TAVR or the newest heart failure medication has required one or two pivotal prospective trials, often blinded and randomized, ways to minimize the bias in the assessment. So in this setting, we've actually conducted one of the first AI clinical trials, which is a blinded randomized comparison of this AI model versus the sonographers or the technicians that actually acquire the images in assessing LV ejection fraction. So I'll walk through this a little bit. In the standard clinical workflow, the great thing about Echo is that every single image has 2 touch points with 2 experts in their own right. And the reason I can describe this is that the sonographer scans the patient, but also creates a preliminary report, and the cardiologist finalizes on a different computer and a different time point, and oftentimes without discussion with the sonographer. The sonographers, in many ways, do this day in, day out, and are clinical experts of themselves. So at Cedars-Sinai at that time, we had 25 sonographers with a mean of 14 years of experience. And then we actually had 10 cardiologists that had about 13 years of experience. Because the sonographers and cardiologists were looking at things from 2 different time points independently, we thought this was a perfect place to do a prospective clinical trial. What we actually did was we shuffled an AI preliminary assessment with the sonographer preliminary assessment, randomized 1-to-1, and then showed them all to the cardiologist without telling them which studies were done by AI, which studies were done by cardiologists, and then actually evaluated how frequently they were changing the prelim to final assessment. And there was a run-in period to make sure that these are high enough quality image so that they're not just uninterpretable. But we were primarily assessing how often did they change the EF more than 5%. There's 3 changes for the model that I described.
Very good question. So is the cardiologist, you have a conditional here, which is you have a condition on the assessment. Would the outcome of the cardiologist be different if they didn't have the assessment? I know that's not what you're testing.
That's right.
But I just realized you have a conditional here.
So the or what I would describe is, reframing this, there's tremendous anchoring when there's a preliminary report.
Right.
You can see that this is across medicines, that if someone created a prelim, depending on what you think of them, you might choose to prefer them or choose to disregard them. Or when I work with a fellow, if it's a great fellow, I might be like, it's roughly okay, this is fine. But we have a separate arm that I'll describe in a little bit. But we wanted to make sure that they were not biased by who the agent of preliminary
That's
was.
exactly what I'm trying to ask.
Yes. So like the standard workflow is that they already have a prelim from the sonographers. So that is not unique or different.
Perfect.
But it is that they do have a prelim. In community practice offices, they might not have a prelim. So there is a separate workflow that I'll describe actually at the end of the talk where they don't, and they have to interpret everything from scratch.
Thank you.
Yeah. But actually, this is a perfect segue in 3 slides. But first I'm going to talk 2 slides and then describe this. But in order to blind the study, we can only show 1 or 2 frames, Sicily to acid, right? Because if we show them something like the top left, they'll clearly know which one's AI, which one's sonographer. So we actually intentionally weaken the AI. But in some ways, we actually improve the AI because we continued the amount of training data we had. So the original paper was trained on 10,000 echoes, and then we continue to train on 144,000 echoes from Stanford. And I wanted to highlight that it's a common known in AI in general, that the more training data you have, the better. Whereas a lot of the commercial offerings, even now, are only trained on about 1,000 images. The last piece, going back to the question of randomization and blinding, is that we actually wanted to study sonographers and cardiologists in the setting that they already use. So this is Siemens Singodynamics, which is the PACS that we use. This first set of tracings were actually done by a sonographer. But I wanted to highlight that when we run Python code, evaluate the model, we re-inject it into the PACS to show this next set of tracings so that it looks very similar. We actually use the back end of the database so that there's, other than the visual quality, there's no way for the cardiologist to assess which is AI or sonographer. This doesn't completely answer your question, but is that even if you don't care about AI, one of the key areas we're interested in is intra-observer variability of clinicians, so that we intentionally chose studies that are already interpreted in the clinical workflow. So this is August 2019 Cedars Echoes. And that means we actually have a historical cardiologist report in the standard clinical workflow. So ignoring everything in orange, if you go through just the 2 blue workflows, you have a point metric of cardiologist variability, because these are 2 sets of the same images that are seen by a sonographer and seen by a cardiologist. So we started with about 3,800 studies. About 7% were low enough quality that the EF was visually approximated as opposed to measured. leading to 3,500 measured that are randomized 1-to-1. This was essentially approximately 1 month's worth of echoes at Cedars-Sinai. It's a combination of inpatients and outpatients, a lot of comorbidities because it's from the cardiovascular center, and Cedars is a tertiary care referral center, and a wide range of kind of, I would say, demographics that represent a lot of cardiology patients. I like to show this to an imaging audience, but even before I talk about the primary results, what you can imagine is that the cardiologist was seeing the images on the middle, and that they're shown either left or right, and they have to adjust these contours to get to the EF they care about. But also after each study, we ask the cardiologist to guess, do you think this was done by AI or do you think this was done by sonographer? And the reason we did this is that we wanted to see if cardiologists could really tell whether it was sonographer or AI, right? Because if a blinded study meant so much more to us than an unblinded study, so the cardiologist guessed correctly a third of the time, guessed incorrectly a fourth of the time, and said there was unsure or could be equal about kind of 43% of the time. This leads to a metric called a blinding index of 0.88, which is considered good blinding. And it's actually very hard for cardiologists to tell which study was done.
Did you look at the images if there were any telltale signs that maybe the AI?
Yeah, no, that's a great question. I'm curious if you can tell or if you had any ideas from these images.
I memorized it. So I can tell now, but I wouldn't have been able before.
So I will say that in hindsight, as we did analysis, you notice maybe this contour looks a little bit more what is it? That Lego-like or kind of Minecraft-like, right? Whoever, whether it's AI sonographer, just clicked 1, 2, 3, 4, and it's much less smooth of a contour.
Yeah.
And I would say that that's actually probably the main tell. Like humans are lazy. They get to roughly the number they want, and they're not necessarily looking to visually approximate the boundary. But if you actually look at kind of the more blocky ones, they're almost always sonographer. So in this setting, the cardiologist changed the AI arm 16.8% of the time, the sonographer arm 27% of the time, which led to a p-value of 0.001 in favor of the AI for both non-inferiority as well as superiority. So we actually initially designed the trial as a non-inferiority trial, but we were pleasantly surprised that it was so much better that it was actually superior to the sonographer. The mean change in EF was about 3% versus 4%, so modest. So it wasn't big changes, but it was more likely that the cardiologist changed them more than 5% for the sonographers. Compared to the historical, it actually had more variation. So going back to your question, is like, if you don't have the anchor of what someone else did, you are actually more likely to be a little bit more variable. So the AI had a difference about 6.3% versus sonographer has 7.2%, so that they had a little bit more spread. And on average, sonographers take about 2 minutes or 119 seconds to do each study. The cardiologist takes about 54 to 64 seconds. And in general, there was change in about kind of 2/3 of the studies. So this was a single center study. It was done at the Cedars-Sinai Echo Lab with a model that was trained on Stanford echoes. In order to blind, the AI was weakened. So this is even the lower bound of what we think the AI can do. There was no comparison with CT or MRI. That said, we are really proud of this study because it's external validation. Again, that's a different site, publicly available code. We have this on GitHub. And through the AIMI Center, we actually released the 10K data set that the original model was trained on. So it actually is very performant. It is one of the few AI trials that had randomization with an active comparator, of which we think that the sonographers are true clinical experts in of themselves. Blinding was successful. And again, even if you don't care about AI at all, this is the largest study of clinician test-retest with 3,500 studies or so. The second largest study we see in echo is actually 200 studies. So this is a much bigger study than a lot of comparisons.
Another follow-up, this is an amazing study. How did you have people who were, I guess I would say, normal, or were these, was your distribution shifted to a particular awkward set of diagnoses? Sorry, yeah.
This is a great comparison. So we actually chose close to sequential for the Cedars Echo Lab for a month. So that's about kind of 3,500 studies. They're about 66 years in age, and I believe that the clinical EF from the historical was about 58% with the standard deviation of 14. So it's essentially, you can think of anything below 50 is abnormal,
Right.
so that this is probably kind of, I would say somewhere between
Slightly biased.
30 to 40% is abnormal.
Thank you.
Yeah, so this would be, in many ways, a true representation of what the clinical or the typical patient that gets an echo, because it essentially all comers.
Perfect.
Actually,
I'll definitely echo that. These are fantastic studies. I'm curious, as you think about software as medical devices broadly, do you think all of them need clinical trials to show efficacy?
yeah, no, it's a fantastic question, and I'll show that this is one that we were fortunate to present to the FDA. But the interesting story behind this is that the FDA, at least for radiological devices, is most familiar with retrospective data. So they were actually telling us that it actually is more work for them to evaluate prospective data because it's a different framework. They would much rather see 3-site external validation with a holdout set that is from geographically diverse, as opposed to prospective evidence. The clinician in me feels that clinical trials are always helpful, because there's clearly parts of human-computer interaction. Kind of the audience member really talked about, the fact that the sonographer anchors the patient or the provider. That is actually really important. That in the current paradigm, it's not. The FDA does not interrogate this. But I think that it's such an evolving, moving place that it's really hard to say that. Or I don't think that the FDA will ever get to the place where they would want a clinical trial for everything, especially as we talk about less deterministic models or large language models, where it's really hard to even think about sample size or think about kind of there's so much variation, and you give it the same input, they might have different things. There's a lot more complexity there. The trial side is really what I think of as on the academic side, is that as Stanford deploys models, probably if you can build in kind of QI or clinical research, that's a huge plus, but it might be that at each site they have to test it themselves. Oh, go ahead.
Sorry, I may have missed this. For the nearly 4,000 echocardiogram studies, is that a public data set or you collected?
The AIMI Center has released 10,000 echoes from Stanford that was used as part of the training set. The images for this trial were not released, but the raw patient level outcomes and results were actually also released on our GitHub as well, so that you can actually see both the prelim, final, as well as AI interpretation for every patient in every study in the study.
Thank you.
Hi. Kind of thinking about the 274 that were unable to be traced by the sonographer, and so it looks like none were unable to be segmented by the AI. Is that right?
So these were excluded, that they did not undergo randomization or we didn't inference. The reason we chose this design is that approximately 5% of the time, the sonographer just guesses or writes 35 to 40, 45 to 50, 55 to 60, and they don't actually quantitatively measure. That's part of the standard workflow because there are so many potentially lower-ish quality ultrasound images. But we think that the model would do just as well on those, or at least the regression model will do well on those, but the segmentation might not look as good.
Thank you.
Can I ask one more question? Based on the results of this study, how do you see this being implemented in the future? Would this be a replacement to the sonographers? Would it be a value-added add-on? How do you think about how to actually use this in the real world too?
No, that's a fantastic question, and I think that it's an area where everyone has strong opinions, right? I think the sonographers are worried their jobs will be kind of automated away. There's a question of like how or where do you integrate this? Is it on the modality side or ultrasound or the PAC side? I often like to say that the acquisition AI piece is actually the hardest to do, right? Because you don't know what you don't know. Because in the PACS you never store the poor quality images or all the images the sonographer never got completely correct. They only acquire the good images. We have a very limited training data set if we want to do acquisition AI. It's really the cardiologist myself that is most likely to be automated away, right? Because it is like these prelims or kind of these things are something that is like tremendously helpful and both can be an area where we offload the sonographer and offload the cardiologist. In a busy clinical environment, even though this is the standard workflow where the sonographer does it and then the cardiologist assesses, this is actually not true at many community centers. So like if you were not at Stanford, if you were at essentially a private practice down the street, oftentimes the cardiologist has to do it all from scratch. Because the sonographer time is so precious, they're focusing on doing more scans. So I would say that there's a lot of value add to potentially standardize and actually improve reporting if you can actually create a good prelim for the cardiologist. I think we're still a little bit far from full automation, but we think that this gets to a very good prelim. So the last piece I would like to highlight is that going to some of these questions that we're fortunate to present the clinical trial data as well as some retrospective third-party validation and show that we were able to get this FDA cleared now 2 years ago. But really this speaks to the long pathway to actually deploy. So this model is actually now deployed at the Cedars-Sinai Echo Lab as part of clinical practice. And we're really excited to really have that. And it's really a multi-stakeholder conversation where essentially stakeholders want it to be actually cleared before using it actually for clinical practice. I'm going to pivot to a second vignette that really focuses on precision detection, but wanted to pause and see if there are so many great questions about EF, but see if there's any other questions here.
I have one more question about the images. Actually, I think the clinical trial you use actually mostly with high quality, right? I think some discussion already touched that. I'm also interested in that, like how does this AI behavior within this poor quality of images? Like, have you ever compared the AI prediction? I mean, of course, the sonographer maybe cannot recognize that well, right? Because you rule them out. But they still have some other modality of data, for example, MRI, or they have a full BNP analysis. We may still have the information about the patient diagnosis. I'm just wondering, like for those echoes, which sonographer cannot analysis, then maybe you can deploy your AI to analysis. Then they may kind of provide some additional information, right? Instead of just direct compare. We may have some more information get from your system.
That's a phenomenal question, and I'll address it kind of two ways. First, I want to highlight the table one is that even among the studies that the sonographers annotated, there was a big spread of image quality. So that in the historical report, we can extract that it said it was poor about 1/5 of the time, adequate half the time, good essentially kind of 10% of the time, and not specify the rest of the time. So even in the ones that we did kind of assess in this randomized trial, there were pretty bad images. I suspect the 275 sometimes is actually due to clinician laziness, right? It's much easier to say 3540 when you have the excuse of saying it's not good enough, as opposed to they're not truly good enough. We haven't done the full analysis whether these are materially different from poor, but like it is actually, I think that the model does well, or we know the model does well in the subset that says poor, because we also have done subset analysis. So in a lot of the metrics we show, not in this presentation, but in the paper, we show that actually the confidence intervals are a little bit wider, but all the point estimates favor the AI in terms of frequency of change and stuff like that. So like even for poor quality images, AI assistance probably is better. The second piece is definitely maybe more opinionated, but in general, we do fewer studies where we do comparison with cross-sectional imaging, because we think that all the modalities have inherent biases in itself, right? I think that implicit when you do comparisons, say that you use the MRI labels, is that you're saying that MRI is better. But across all studies, you already, even outside of AI, show that there's not perfect correlation with echo and kind of MRI. And it's also, from my perspective as a cardiologist, not the right clinical standard. Because if you think about patients that go to a clinical trial for heart failure, stuff like that, patients are essentially enrolling because of their echo. People are making clinical decisions because of their echo. The 1 to 5% of patients that are getting CMRs, it might be helpful, but it's actually not how clinical practice is done. Like, this might be a little bit of a hot take, but like, if there's discordance between the echo and MRI, I'm one of the rare persons that would say you should probably use the echo results as opposed to the MRI results. It's not that the MRI results for quantitative measurements are actually much clearly better and are oftentimes validated on smaller data sets.
Thank you.
So that's definitely a hot take in our radiology audience. I'll definitely
Throw it out there.
So you can take it for what it will.
There's no tomatoes for lunch. So
we can have a beer later and discuss at the bar. All right. So I'll talk about the second vignette, which is about precision assessment of rare diseases. But I'll start first with the patient vignette. 85-year-old gentleman, HFpEF, AFib, sick sinus, carpal tunnel syndrome, that underwent a large workup in 2019. His EKG shows that he doesn't quite meet low voltage criteria, so wouldn't meet the classic definition of a particular disease I'm thinking of. His wall thickness were measured at 1.3 centimeters, which is abnormal, but maybe if you look at with the benefit of hindsight, maybe the sonographer under-measured these walls, right? Maybe if I had to measure, I might squeeze this out a little bit further so that it actually had more left ventricular hypertrophy. But I'm talking a vignette about cardiac amyloid. It's kind of an area of kind of more and more interest because there's new therapeutics that actually improve life expectancy as well as improve quality of life. But in this setting, you can see even at a tertiary care center where this patient was reviewed by imaging from many different specialists and cardiologists, people are not getting a diagnosis of cardiac amyloid because it's a rare disease. Like at Stanford, there's great clinicians that see these patients. Kind of Ron Vitalis is an amyloid expert, as among others, kind of Paul Chang, and I would say Kevin Alexander. And then there's a lot of phenotypic mimics. So hypertrophic cardiomyopathy can also cause increased wall thickness. So kind of Ewan, as well as many others, will see these patients. But even with specialty care, oftentimes patients need to see about 4 specialists in about 2 to 3 years before they get this diagnosis of cardiac amyloid. So in this setting, even though we're seeing all these patients are getting echoes, that diagnosis is not reaching up to the top of the surface because as an imaging person, we have a lot of signals that are suggestive, but nothing that is convincing. So that when I actually searched the word amyloid in the Stanford Echo database, and it's really said 300 times in about kind of like 300,000 echoes. And most of them are actually for patients that are known to have cardiac amyloid in which they're getting follow-up echoes. Rarely is the imager actually saying, consider cardiac amyloid, even though there are imaging findings. So in this setting, we actually created a 2-fold AI model, which did 2 things. First, we actually used the model to have a precise assessment of wall thickness. So similar to the idea about EF is that the more you can do it beat by beat, frame by frame, you can actually have a more precise measurement that increases your pretest probability. And among patients that have left ventricular hypertrophy, we can actually distinguish between the etiology. So whether it's AS, hypertension, hypertrophic cardiomyopathy, or cardiac amyloid, we actually did a paired training where we actually trained the model to distinguish between the etiologies, even though all of them have hypertrophy. We found that this model did better than if you actually just use age and sex matched controls, because the model tends to shortcut on not having hypertrophy if that's a lot of your controls actually do not have LVH. This actually allows for a more precise model, and ultimately, we're interested in actually seeing what it looks like in clinical workflows. The main challenge in clinical medicine is really in the US, this is being diagnosed 7,000 to 10,000 times a year. If you actually estimate the incidence, it could be closer to 20 to 220,000 cases a year. And really, it's the diagnostic chasm is echoes, because there's rarely a patient with shortness of breath or being seen by a cardiologist that does not get an echo. And it's interesting enough, 1 in 5 Medicare beneficiaries get an echo every single year. So this is really the top of the funnel, right? You can only go further maybe with EKGs, but this is essentially, probably many of you guys in this room have had an echo, so it's a great screening modality. Roxana?
You were saying there's new treatments. Is this one of those things where early intervention actually makes a difference in outcomes?
That's a great question. Yes. So there's downsides and upsides in early intervention. All the clinical trials for amyloid drugs have a bigger effect size for NYHA 1, 2, 3. So like the earlier diagnosis is more likely to be at a reversible place. If you actually strictly limited those trials to just the sickest patients, there would be negative trials because it's protein deposition of the heart. If you deposit too much, these medications don't do too much. The downside, and to be fully cognizant of this, is that these are expensive medications, right? These are part of the interest where you see so much marketing and stuff is that these are drugs that cost between 60 to 250K a year. In this setting, we are doing a prospective trial at 4 centers. This is being done kind of at the Palo Alto VA, at Cedars-Sinai, at Northwestern, and Providence in Oregon. But the general workflow is that we actually scan through all historical echoes from the last 3 years for each of those sites. That creates a histogram that's on the top right, where 0 means unlikely amyloid, 1 means high likelihood for amyloid. You can see the vast majority of patients are unlikely for amyloid because it's a rare disease. But then, if you actually spread it out based off a proportion that actually had known diagnosed amyloid, you'll see that patients above 0.8 actually have a high pretest probability of amyloid. And this is even for patients that never had a diagnosis of amyloid. So the suspicion is that these are patients that should be evaluated by a clinical expert, see if these are patients that actually would have a diagnosis if they actually saw those experts, and exclude. And we don't necessarily need to see the patients that already have an amyloid diagnosis. But this is similar to kind of a lot of Akshay's work, this opportunistic screening. If people are getting an echo for AFib, but that AFib is because of cardiac amyloid, this is a way to surface it to the very top. We're fortunate to say that this is also FDA cleared. This is the tension of this slide is also recognizing that this clinical trial has not actually completed, but a clinical trial is not needed to clear this essentially an algorithm, and we've actually validated this and retrospectively at many sites. But this is really the paradigm of actually can we use AI to detect things that we're not very good at calling, or detect things that the images actually provide that information, but we're rarely kind of surfacing to the top.
Were you able to understand which features are looked at by the AI? Are you able to do the same thing now that you know that it's possible?
Yeah, it's a great question. I would say that right now we're still confirming whether these people have amyloid, but most of these are convolutional neural networks, so there's not you can do GradCam, you can do a variety of approaches. It's a little bit like tea leaves, but I wouldn't say that there's a clear, definitive new marker of amyloid. Oftentimes they're things that when you show the clinician in hindsight, oh, that makes sense, right? That's hypertrophy or a little bit of kind of thickening of the valves, a little bit of kind of pericardial effusion, but it's just as the imager, you're not calling this enough.
Does the model only see images or also EKG and
just the images? So just the apical 4 and the parasternal axis images.
Can I just quickly ask what the predicate device for this was?
So the predicate for this was actually, there are now 3 amyloid detection models in the market. We were the second. So the predicate was actually, Ultramics has an amyloid detection model as well. That works just in the 4-chamber view for ultrasound.
They also do landmark detection, or?
Pardon?
They also work with landmark detection?
They do not do any landmark detection. So our model is the combination of the wall thickness and parasternal axis, and then disease classification on the 4-chamber. They cleared a model that is just the disease detection on the 4-chamber. So I really like this paradigm because I think of it as getting more value from the imaging that we're already obtaining. Clearly, amyloid is an area where we have a lot of life science interest, where we can see there's value. But the other idea is that I think it's a stylistic or thematic thing that can be true for many things that we're missing on imaging, right? It gets back to the question of like, this is the tip of the iceberg, and it's really the limitations of the clinicians that make it so that we're not able to get as much value or as much possible value out of the images. So one example I like to give is that in an echo study, which is cardiac ultrasound, there's about 100 images. 3 to 5 actually contain images of the liver, but I have never called anything in the liver, even when I, as a cardiologist, see that this doesn't quite look right, or this looks a little bit weird, but I want to stay in my lane. I, as a cardiologist, want the kind of the radiologist to read abdominal ultrasounds. But if you go back and look at it, many of these patients never get an abdominal ultrasound, right? These are patients that maybe some cardiologists called it HFpEF because the heart looks completely normal and the EF is normal, but they have a little bit of edema or they have a little bit of swelling. But actually, in hindsight, this is actually all related to cirrhosis. So the idea of this paper is that we actually train a model that does view classification, grabs all the liver-focused images in an abdominal ultrasound or in a cardiac ultrasound, and then a classifier to actually detect whether there is fatty liver disease or not, or whether there's cirrhosis or not. ultimately, we're never going to say that patients should get a cardiac ultrasound to screen for liver disease, but among the 1 to 5% of patients that have abnormal liver findings, this is a way to actually get you closer to the hepatologist or get you closer to the radiologist so that you actually get the definitive training that you need. So we're really excited that the American Heart Association has recognized obesity as actually one of its core themes or kind of ideas for the kind of next couple of years, which is kind of about metabolic health. And this is really a unique place because echo, or patients who get echo, actually are enriched for fatty liver disease and kind of the risk factors for MASH or MASL. They tend to be more diabetic, they tend to have more obesity, they tend to have more high cholesterol, all of these things that would suggest these are a higher proportion of patients that have metabolic syndrome. Oftentimes it's at the earliest stage of their disease where they're just feeling a little short of breath or not exercising very well. But this is an opportunity because there's now GLP-1s or there's actually MASL-specific therapies. We're actually rolling this algorithm out, actually both at Stanford with kind of Long, Alex, and a variety of people, and kind of Stephanie, where we're actually going to do this driven by a hospitalist to see what happens for inpatient echoes and have them evaluate the chart and consider referrals as necessary. We're also doing this at Kaiser as well as MGH and Cedars, where we are actually going to get hepatologists to review the findings to see if they need additional testing, including abdominal ultrasound. Yes?
So you mentioned before that there's a pre-selection of images that are then sent to PACS. So in this case, do you run this during the scan, or do you run this on the selected images that are sent to PACS? Because I imagine if there's a liver, maybe it's not sent to PACS if it's a cardiac.
It's a good question. It's a good question. So the liver images are always sent to the PACS because that's how we assess right atrial pressure. So we actually get views of the IVC, and that's necessary for a full echo report. And those IVC views are always looking across the liver. But that said, I think it's a very nuanced and important question about, is this real time or not? So this is a pragmatic trial. It'll vary by study, but you can imagine for our EMLO trial, it's not, we do not need it real time because it could be, we call people back from months or years behind. But especially for the Stanford workflow, we anticipate these will be inpatients. So it's actually much more important that we actually do this in near real time. So the kinks are still being worked out, but the goal would be that potentially the echo studies were sent to a research server and then kind of pinged us, a hospitalist, actually before the patient either goes home or they might have to call the patient after they go home. Right. I'll pause here until my third vignette, but are there any questions about opportunistic screening?
Maybe a quick question about how challenging is it to run these on the machine for ultrasound? Technically.
The machines themselves are locked down, and that's why kind of most of our research projects are on the PAC side, right? There's standard APIs to grab and pull the images. I know that there's a lot of interest from the ultrasound manufacturers to even think about putting GPUs on the computers, but in general, because it's a privileged space, we've not been able to do much research that's actually on the ultrasound carts. Okay, so the third vignette is really kind of this idea of agentic AI. So as AI has gotten more and more powerful, and we see kind of more and more models that can strum along, potentially we can do more automation in a way that actually the cardiologist or the sonographer can essentially be more of an orchestrator, or actually look at things from a more complete stage. So we published a paper called Echo Prime, which is actually trained on essentially 275,000 studies from Cedars, close to more than 12 million videos, where we actually used a contrastive approach, where we trained essentially to combine or kind of random shuffled images, report text, actually link them together to help the model determine what is actually the most relevant text for the most relevant videos. And also, intrinsically as part of that process, the model learns view classification. So it recognizes what are actually the most important views. So the views on the x-axis work to identify what parts of the cardiac structure on the y-axis, so that the model actually can choose which videos to grab from the 100 videos to actually weigh more or less. So this is a model called Echo Prime. We were fortunate it was published in Nature last year, but the general idea is that you can feed it all 50 to 100 videos. And for every part of the report text, it actually can, so like the left ventricle, it grabs the 9 most relevant videos and then comes up with the report text. So for example, this one is about the right ventricle. All these videos have the right ventricle in it. The next one is about the left atrium. All these videos have left atrium in it, and then it comes up with a consensus assessment of what the cardiologist would have said if they're finalizing that report. This is an area where you can imagine this creates a very good preliminary report, even without direct measurement. But we are also interested in direct measurement. So we have a simultaneous model called EchoNet measurements, where we actually do all of the point-by-point landmark detection and measurement between the landmarks to create the most common wall thickness, kind of chamber size, and essentially assessments of diastology using essentially segmentation models. The combination of these two models, we think, is actually a very good comprehensive assessment or preliminary assessment for the cardiologist, where we hope that beyond just the benefits from the EF, which again in our trial suggests there was about 2 to 3 minutes of time savings, that this could actually completely short or kind of replace some of the intermediate benefit or workflows for the cardiologist sonographers to actually really streamline their workflows. So at Kaiser currently, we are running a very similar design study, which is a non-inferiority clinical trial, where we are actually getting sonographers to reread historical images and then shuffle them to a cardiologist for blinded review. But the fun part of this study is actually going to this gentleman's last question, is that we've added a third arm where we're actually having the cardiologist review it without any preliminary assessment to see if actually, if you then shuffle that into the third, so it's a third, our cardiologists more prefer a cardiologist interpretation, a sonographer interpretation, or an AI interpretation. I'm really hoping the cardiologist isn't too bad, but this is actually making me a little nervous, right? But this is actually something we've actually just done all the prelims, and we're actually organizing the shuffling, and we're hoping to have a readout probably by the end of this year. Okay.
Are you tracking the time duration also in addition to your?
Yeah. That's right. That's right. So like a lot of the, the conversation we have stakeholders like also to prove the business value as well as the clinical value. So we want to show like, hey, this saved your cardiologist X amount of time and stuff like that. And going back to the idea is that, at Stanford, it's great that the sonographers actually do a lot of the prelims, but at most Kaiser Northern California sites, there is no prelim. So this is actually very laborious for the cardiologist to do. So we do actually want to evaluate what it looks like when there's no assistance from anyone.
In addition to the imaging, do the people who are reading these also get the rest of the medical record at the same time, including the AI system?
In this trial, they do not get the rest of the medical record because it's blinded, and we actually extract it away from the MRNs and stuff like that. But I would say that that's more in line with the clinical approach that most clinicians do now. We're so inundated with the number of studies that have to be reported that rarely do people look into the chart to help adjudicate whether they believe something or not. It's really, for most echo reporting workflows, it's just do the images show it or not.
And I was nudging because of multimodal, so that's it's just where the AI could go, and I just was wondering.
No, that's a great question. It at least at this point, it's a combination echo prime and echo measurements, but it's purely imaging based.
Perfect.
Yeah, in terms of the outputs, do you have like a template of the report generation? So the video that you showed us, what is the final output that the cardiologist gets to see?
Yeah, the cardiology uses something called structural reporting. So more than radiology, a lot of the reports are actually more structured, and there's kind of set boxes to check and stuff like that. That was partly determines how we train an echo prime. Even though it's contractive, it's then fine-tuned on actually the structural reporting template. But it is actually, there is a more narrow scope, is that it's not pure, like any language can go into the output. And it also potentially helps the blinding as well. It's unlikely the model will say, I don't know, make some random free text stuff. Okay, so I will have 2 more slides and would love any questions. But the first is that I want to reiterate the idea of like performance scales with data. So we're fortunate, and one of the exciting parts of kind of my move to Kaiser is that we think that we will have the most performant models because we have a lot of data. So Echo Prime has been published, but even before, we've actually trained a new version of Echo Prime that's being used for this clinical trial that is roughly another 10x in terms of data set size. And we hope that that would improve and make more likely that the model will be performant. And the second piece, I would say that I'm, along with Roxana, one of the editors at New England Journal AI. Please submit to us if there's anything that you guys are doing. We're always interested, and we can quickly give you feedback if we find it interesting or not. But a North Star for us is actually prospective deployments, whether it's randomized or clinical trials or just in terms of QC. But we're very interested in both development and deployment of kind of models across radiology. Again, parroting the concept that cardiology just copies a lot of radiology, I'm the chair of the ImageGuideRegistry for the American Society of Echo. We really admire what RSNA has done, so we're actually creating a registry of publicly available echo images that we're hoping is an external test set for both commercial and non-commercial options. Right? We think that this is really what the society should be doing, because right now, at least cardiologists are seeing so many marketing press from all the companies where, like, our models are perfect. But there's a lot of hesitation because I don't think all the models are perfect, but an external benchmark that they're not training on is actually worthwhile as a society. All right, well, really excited to be here, and thank you so much for the invitation, Akshay.
That was a fantastic talk, David. Thanks for walking us through so much fantastic technical development, clinical trials, and really deployment. And thank you for being patient with all the questions we kept asking.
No, I love the questions.
Yeah. I know we're formally out of time in a minute or so, but I think we have David for a few more minutes. So maybe we can just do more Q&A. So if you have any questions, please, yeah.
It's brilliant talk. Actually, can you go back to the last second or last third, like the slides about the curve? Yeah, I think as you can show here, it's a learning curve seems to go to the plateau quite soon, right? So you already trained with a so big data set. I'm just wondering how about the next step? Are you going to just include more and more, echo data, or you're going to go to multi-modal approach? Because I think echo provides absolutely essential information, but it's just one modality of the clinical data, right? I'm just thinking whether you consider to include some, for example, patient symptom or some blood test to, make this diagnosis even more accurate, not just suggestive, but also maybe really help the clinician to get the diagnosis directly.
Yeah, it's a fantastic question, and maybe this is an unsatisfying answer, but the answer is both. We're both creating multimodal models as well as single modal models with large data sets. The limitation for a lot of the multimodal approaches we've been using is that the more modalities you use, and then you constrain that all the inputs need all the modalities, becomes a smaller and smaller data set. So what we've essentially done is that we have a multimodal model called Cleric, but then if you use the subset that both have EKG and echo and angiograms and chest X-rays, all these things, it becomes smaller and smaller because a lot of times people don't have all the modalities. And then you can censor or you can use NAs for a lot of the contrastive approaches, but it becomes a very nuanced question whether that actually helps compared to just a larger scale of a single modality data. Our internal trials have suggested it is not superior to just a lot of data from one modality, but I think it's still an open area for research.
The size together with the slides that you showed in the beginning with the pigeons. One fun thing about this paper was that what worked best in that study was if you chained multiple pigeons together and had them vote as a flock. So in machine learning terms, you create an ensemble of classifiers.
Yeah.
And I wonder if, in the same sense, have you tried multiple agents in your Echo Prime approach working together?
It's a good question. I think that the closest we've tried is that we've tried a variety of weighing approaches because we actually get an inference per video. So like a lot of our kind of multiple instance learning has been, certain view videos and kind of, we have actually essentially 100 votes, but how do we prioritize which of the votes for each of the videos is where we're doing a lot of this. We haven't done as much try to train from scratch different weights and then you doing the same task and averaging them.
Yeah.
And in radiology, there's this attempt to tailor the acquisition size so that it's more suited for AI analysis. You said you have 100 videos. Maybe we just need 10. You think that in the future the sonographer can get a signal, you're done, you have what you need, and cut the time.
Yeah, I think that's very much the goal. It is, I think that we can actually decrease the acquisition time and actually interpolate. There's a lot of value. A lot of imaging data is overlapping, so I do believe that we're spending more time than the bare minimum.
Can I ask the complete opposite question of that? This is based on your slide about CKM. Really, we've been looking at cardiac disease or hepatic disorders.
Yeah.
But maybe for every echo, we should always be assessing the liver. We should always be assessing other organs. Do you see value in approaches like that, especially when they're aided by AI, so we don't have to spend 20 minutes per sonographer? But do you feel like that's where we should be moving as a field, that we want to do comprehensive analysis of the whole body as much as we can?
Yes, I'm as a clinician, as a researcher, I'm very in favor of that approach, because I think that, as you're mentioning, it's a lot of you don't know what you don't know. Similar to my answer for the image acquisition problems, like image acquisition problems are hard because we don't store the data. The more data we already kind of routinely acquire as part of standard workflows, the more the opportunities in the future are. And if you look at it from a global perspective, that's actually where I think that the US is dominant for medical AI, because intrinsically the US actually does more acquisitions and does more imaging than the rest of the world. In many parts of the world for echo, it might have been actually for, let's say, China or India or kind of other places, they only do acquire 2 or 3 images or 10 images. So it is insufficient, and they're not able to train models the same way that we're able to in the US.
Well, thank you so much, David, for taking the time and sharing all this fantastic research with us. Let's give David another round. Thank you all for coming, and see you again next month. Thanks all.